Okay, carry on. Start presentation.
A 45-year-old male rancher is admitted with history of fever of 6 weeks duration. Fever is fluctuating with chills, feels unwell, anorexia is present, weight loss of 6 kilograms, and now for the last 1 week he has features of cough and dyspnea on effort. He also has pain chest and severe low backache. On examination, On examination, fever of 40 degrees Celsius, pulse rate of 100 per minute, respiratory rate of 28 per minute, BP of 110 over 80 millimeters of mercury, and a few non-tender form significant lymphadenopathy is present. Next notes.
Yes. So, what do you make out of this case?
Okay, the patient is a 45-year-old male rancher, which means that he is predisposed to zoonotic diseases.
Yes. Okay. So, what are zoonotic diseases you know of?
Okay,
What name one common
maybe
zoonotic disease in our wards?
leptospirosis.
Leptospirosis. So, is this patient having leptospirosis?
Uh, Leptospirosis presents with fever and myalgia typically. This patient has complaints of more of arthralgia, low backache.
What is the duration of fever in leptospirosis, and what duration of illness in this patient?
This patient has about a 6 weeks duration of
So,
fever.
common things, short-lived fevers are all ruled out. No,
Yes, sir.
short-lived fevers
Yes,
are
sir.
all ruled out. But the common. So, what is PUO?
Pyrexia of unknown origin
It's
is
defined as
fever,
lasting.
fever of more than 101 degrees Fahrenheit, uh, of duration more than 3 weeks, and the cause of which has not been found out even
Routine
after 1 week
investigations.
of inpatient evaluation.
Okay, so you think this is a case of PUO?
Yes, sir.
Yes. Okay. What is the second sentence talking about this patient?
Fever is fluctuating
Fluctuating with
with
the
chill.
chills. Okay, fluctuating the fever. What is Pellepstein's fever?
It's a fever typically seen in Hodgkin lymphoma.
Hodgkin's lymphoma. And what are the periodic fevers you know of?
Um, in malaria,
Malaria is not that's intermittent fever, but not period. Periodic fever comes and goes in clusters. No, periodic fevers. Familial Mediterranean fever,
yes, sir.
hyper IgD syndrome. Okay.
Yes, sir. Okay, sir.
Any other traps? What is traps?
Um,
Any other?
uh,
Needu. What is traps? Name the other periodic fevers you know of. Yes. Along with familial Mediterranean fever. What is the treatment for familial Mediterranean fever? What drug will give? Colchicine. What complication can come if you don't properly take care of the patient? Can it produce amyloidosis? It can produce amyloidosis. Okay. Is this traps any relation to TNF?
TNF is associated periodic fever.
That's right. Okay, so you have got different types of periodic fevers. So this patient is not having periodic fever; it's a continuous fever. Yes, and this patient has got anorexia and he has lost weight, 6 kilograms, significant weight loss. What do you mean by significant?
More than 10% weight loss.
He has
or
lost. Okay. Then he has got pain testis. So how do you look at
yes,
that problem?
orchitis,
Is it very common in Kerala or rare?
rare.
It's very common. You see people with the filariasis, they have got pain,
Yes,
testis.
sir.
People with STDs have got pain, gonorrhea, chlamydia, mycoplasma, other causes of pain in the testis. Have you heard something called parotitis?
Yes, sir.
Can you have orchitis? Can you have
And
pain in the testis in polyarteritis nodosa? Dilruba.
polyarthritis.
Pan. Polyarteritis nodosa is what is polyarteritis nodosa?
Small vessel vasculitis.
It's a medium vessel vasculitis affecting the arteries, and it can have varied manifestations. What are the common presentations? Can it present as PUO? All vasculitis can present as PUO. Fever is a very common presentation. Other presentations of polyarteritis nodosa. Yes.
Renal problem.
What renal problem? They don't get glomerulonephritis. Kidneys are affected because the vessels are affected. There can be areas of infarction. Urinary sediment is not a feature of polyarteritis nodosa. Which other system will get affected? Usually they come with palpable purpuras. They come with abdominal pain, ischemia, gangrene. They come with mononeuritis multiply. What do you mean by mononeuritis multiply, Parvati? Multiple peripheral nerves are getting affected sequentially, temporally at different times, one after another. That's called as, so they are asymmetrical, comes and goes. Once you get a ulnar palsy, next limb is a radial nerve, that is foot drop, like that keeps on going. Sequential, not unlike peripheral neuropathy, they are not symmetrical. They don't start together. They come asymmetrically at variable time. Time frame is different. So what are the common causes of mononeuritis multiply, Kartika? Common causes. You get in diabetes mellitus, you get in vasculitis, neurofibromatosis, Hansen's disease. Hansen is not a classical, it's an insidious onset. Vasculitis and diabetes mellitus is very classical to have mononeuritis multiply. Okay, so polyarteritis nodosa comes with abdominal pain. You can demonstrate aneurysms by doing MR angiogram. Okay, there are significant lymph nodes in the neck. In this background, what's the differential diagnosis there?
Fever, anorexia, and multiple significant neck lymph nodes. We have to consider the possibility of infectious mononucleosis.
Infectious mononucleosis producing cough, dyspnea, and weight loss of this much duration is rare. Infectious mononucleosis is a short duration illness. There can be cervical lymph nodes. I agreed, but not the other components. So I put everything together. Infectious mononucleosis looks unlike other conditions which can have weight loss with the lymph nodes, the neck with the fever. First thing that comes to your mind will be
The lymphoma.
tuberculosis. Tuberculosis tops the list. Then you can have retrovirus infection. Second possibility. Okay. Then you can have SLE, simple SLE. You can have lymph nodes in the neck. Sarcoidosis you can have. Okay. Histoplasma you can have. So different entities are there. infected diseases, non-infected diseases. 45-year-old man can have CLL. So differential diagnosis will be quite variable. An abdomen examination, what did you get?
There is hepatosplenomegaly and splenomegaly of 3 centimeter, soft, firm, mildly
Soft
tender.
to firm, mildly tender, and hepatomegaly 4 centimeters, non-tender. Okay, so with this hepatosplenomegaly and fever of 6 weeks duration, what all things comes to your mind?
And considering the possibility of zoonotic disease, we have to think about brucellosis.
Can you get hepatosplenomegaly in case of leptospirosis?
Yes, sir.
You can have. You can have. Yes. Can you have hepatosplenomegaly in fever 6 weeks duration in typhoid fever?
Yes, sir.
You can have. Can you have same picture in endocarditis?
Yes, sir.
You can
Infected
have.
endocarditis.
What about malaria? Hepatosplenomegaly fever is possible, but the appearance of lymph nodes,
Not,
lymph nodes, not okay. Toxoplasma,
yes, sir.
yes, you
Yes,
can
sir.
have lymph nodes. You
Yes.
can have lymph nodes. SL is possible, sarcoid is possible. So they are wide differential diagnosis. Testis is tender. So what are the possibilities you consider here?
Um, Erythema operatus
Due to what all
or
conditions?
STDs,
STDs, yes, gonorrhea, chlamydia, mycoplasma, yes.
uh, viral,
Which virus? Very good. Which virus?
mumps,
Mumps. How often you get it?
rare complications.
33%, one third. Not very rare. Any other condition which can produce tenderness and testis?
Uh, Non-infectious cervical cause like torsion.
Torsion, very good. Torsion, yes. Varicocele.
Yes, varicose.
Can filare produce testis tenderness? Okay. We have GISA. Can you have tenderness in other medical problems? Yes. Polars nodosa and brucellosis you can have infection. Now, cardiovascular system, what are the findings?
There is a grade 2 systolic murmur over the apex.
Over to Dilruba, what do you think about this murmur?
Sir, grade 2 systolic murmur in apex.
Yes. Is it
Is there
organic
any other?
or functional? No other finding. How do you decide whether murmur is organic or functional? What are the
Sir, it is
golden
associated with
rules? What are the golden rules and silver rules?
if the murmur is associated with thrill, if it is more than grade 3 and if it is radiated to the base of the heart, it is organic.
Usually, you look at what you said is correct. You should look at the accompaniments, symptoms, especially edema, raised JVP, abnormal type of pulse, thrill. So accompaniments will decide whether a murmur is organic or functional. Point number 2 is S2, particularly P2 and A2. You look how they are. If P2 is normal, not exaggerated, not muffled, then you can think about this is a functional murmur. So if the E2S2 is abnormal, then most likely you are dealing with a organic disease. There are two golden rules in deciding functional versus organic, and there are three silver rules. What are they? Silver rules: if there is a late systolic murmur, it's always organic. If there is a diastolic murmur, it is always organic. And if there's a continuous murmur, usually they are organic, exception being venous hum. So what is meant by a continuous murmur, Parvati?
Murmur that is heard throughout the systole and diastole without
Okay.
even during the F2.
So Needu would like to say something more? Continuous murmur is defined as
during starting festival and goes along with
this continuous murmur need not fill systole, continuous murmur need not fill diastole. Continuous murmur is a murmur that starts in systole and crosses over a second sound to diastole. Got the point? So if you got somebody with a mitral regurgitation, aortic regurgitation, that will not be called continuous murmur. Same murmur is crossing the second sound. That is called as continuous murmur. So venous hum. So Parvati, back to you. What are the features of venous hum? Okay, Kartika, features of a venous hum. Okay, Merlin, what is meant by venous hum? We feature the venous hum. Venous hum is always heard in the neck. 2. It is a continuous murmur. It is heard over the base of the neck and increases in inspiration, and when you turn the head to the opposite side. It decreases when you turn the head to the same side, and is best appreciated when the patient is sitting up. So sitting up, base of the neck, head turned to the opposite side, increasing on inspiration, you hear this continuous murmur, and you put your finger above the stethoscope, just above, you can obliterate the vein and the venous hum. The murmur decreases as you turn to the same side, and as you lie down, an expiration, it becomes less. Which are the conditions where you get this, Merlin? Parvati? Commonly heard in anemia, hyperdynamic circulatory states like thyrotoxicosis, you can hear. Rarely it is palpable with a thrill, commonly no thrill. So basic thing is how to differentiate a systolic murmur, organic versus functional. There are no clues that the murmur we described here is an organic murmur. Commonly the functional murmurs are heard in the base of the heart, namely right and left second intercostal spaces. Respiratory system, what are the findings here?
Bilateral scattered crackles.
Crackles are heard, nothing special about it. Scattered crackles are heard. And locomotor system, FABER test is positive on the right side. FABER, how do you pronounce it? Faber's test. Faber's test is positive on the right. What does it mean to you?
Figure of 4 test for sacroiliac.
Yes, that means F stands for flexion of your hip.
Flexion.
AB stands for your abduction of your hip, and ER represents external rotation. When you apply pressure, and patient localize the pain in the sacroiliac joint and over the groin. This is called as Faber's test. Indicates so this patient got right-sided sacroiliac pain. Okay. So this patient presents sacroiliac pain. What are the presentations of sacroiliac pain? You are talking the causes. Okay, ankylosing spondylitis. Usually they are bilateral. Yes.
Yes.
Other causes of sacroiliac. In India, when somebody is coming with fever with sacroiliac arthritis, especially when unilateral, as in this case, first possibility is tuberculosis. So brucellosis, well, it can have. Any infection can spread to sacroiliac joint, and it can have arthritis there. And unilateral is also seen in other causes of seronegative spondyloarthropathies. Like, okay. So you can have reactive arthritis as a cause for unilateral sacroiliac arthritis. So we have put all together fever in a rancher 6 weeks duration. And an important point is the fluctuating fever. Yes. And with the affection of the respiratory system, suspicious affection of your cardiovascular system, significant lymph nodes, weight loss, spleen, liver, tendons of testis and sacroiliac joint, scattered crackles, murmur. What possibilities all come to your mind? Brucellosis is one possibility. Yes. Can this be tuberculosis still? It can be. Yes. Can it be leishmaniasis? Yes. Possible. Yes. Can this be toxoplasmosis? Few features are there. You cannot explain the testis tenderness and sacroiliac arthritis, but the possibility is there. So, can this be typhoid fever? Typhoid affects almost all parts of the body.
Yes,
So that is still possible.
yes.
So this was a patient in the ward. Okay. So how are you going to investigate this patient?
Blood investigation, starting with complete blood count.
Blood count, and you found that this patient got blood count of 3900, polymorphs 50, lymphocyte 50, platelets normal, ESR is 50, hemoglobin is 10. What else you want? When you find this count 3900, what does it mean to you?
Leukopenia.
What does it mean? Inference. Commonly, it is against the diagnosis of bacterial infection.
Bacteria.
But there are bacterial infections like tuberculosis. You can have this count. There are infections like Brucella. You can have this count. But commonly, we think whether this patient is having some viral disease.
Viral.
Okay. Typhoid fever, you can have low or normal count. So possibly still remain open. What other investigation you want?
The liver function test.
Liver function test, just elevation of enzyme, bit elevation, marginal elevation of liver enzymes. Any other thing you want?
The blood culture.
Blood culture was sent, but they say there's some growth, but it will take time. Meanwhile, you want to do any other investigation? Would like to do an X-ray chest and see,
Yes, sir.
and it was showed interstitial shadowing. New sputum available. Patient became breathless, and you did a HRCT that also showing interstitial shadowing, interstitial pneumonitis. Would like to look at his CVS.
Yes, sir.
Yes.
Echocardiography.
That is normal, and you want to do an X-ray of his sacroiliac joint.
Yes, sir.
That's also okay. What investigation you plan if it's a case of typhoid fever?
Viral test.
Week 1 we go for blood culture, week 2 we go for viral test, week 3 we go for stools, and week 4 we go for urine. So here is a 6 weeks history. So blood culture can be sent, agglutination can be sent, but stool culture, urine culture will have to be our other targets. Okay. bone marrow in this case?
Yes.
Ele-
So,
Pardon?
toxoplasmosis.
The bone marrow, if the blood culture is negative, if you are not coming to any other diagnosis with the available investigations we suggested, we may go for a bone marrow, and you may do a culture also bone marrow. You may
Okay.
look for malaria, look for kalas are there, he has spleen and liver, fever long time, kalas are possible. You can look for toxoplasma, you can culture for typhoid bacillus, you can look for AFB, you can culture for brucella, and you may get evidence of leukemia or lymphoma if at all it is there. So many possibilities comes to your mind, and that will give to later date. So this particular patient blood culture came as positive for brucella. How do you proceed?
Um, Start him on antibiotics.
This patient is a modified version of the patient who was in the ward with hereditary spastic paraplegia, recently discharged. Because all of you have seen the case, I just twisted the case history and put it. And being a first year class, I gave the clue. He is a rancher.
Yes.
So I modified accordingly, and I put sacroiliac arthritis and pain. The test is extra points, but the respiratory findings were there. Okay, liver and spleen was there. Other things were provided to you to make it interesting. This is a case the ward culture proved
Yes, sir.
culture proved case. So what is a brucellosis?
It's zoonotic disease.
So now now the Karthika will start speaking. What type of organism is grown in brucella?
Gram-negative bacteria.
Yeah, bacteria. Bacteria means coccus or bacillus.
Bacillus
Coccobacilli, yes.
is
So
gram-negative.
why it is called as brucella? It shall be from the name of Bruce who described it. Okay, David Bruce is the man who, the physician from Australia. Is there any other name for this condition?
Undulant fever.
Why it's called undulent?
Because of its remittent character.
So very much fluctuating fever. Any other name? Why it's called Malta fever? Is it more commonly seen in Malta or first described in Maltese? What is the route of transmission of this disease?
By aerosols.
Pardon?
By aerosols or even by ingestion.
Injection of what?
Ingestion of milk products, milk or milk products.
Okay,
And
so
by aerosol generation of cattle or sheep or even dogs.
so it can be ingestion. Rule of I, 3I, ingestion, inhalation, inoculation. Anything is possible. How is it getting inoculated? Inoculation comes from where?
From fecal matter of these cattle.
Fecal matter of these cattle, yes. Laboratory workers, they get this through their skin, through conjunctiva. Okay. This can be transmitted to blood transfusion, even through transplantation of organs. Breastfeeding can transmit the disease. Sexual contact can have transmit disease. Okay. So in some cases you may not get a source of infection also. So what are other investigations you plan in this case? What?
Blood culture IgM brucella.
Yeah, brucella agglutination titer in high concentration in an endemic area. So which are the endemic areas you know of?
Tropical rainforest.
Is commonly seen in the Gulf countries, camels. Okay. In India, Orissa, they had plenty of cases of brucella. I don't know how far it is there now. A couple of years back, they had plenty of cases, and majority of their patients were having arthritis as a presentation. So, what are the investigations you plan for his backache? X-ray.
X-ray spine.
X-ray span, what do you expect to find?
Usually brucellosis will involve the lumbar vertebrae and there will be multiple vertebrae involvement.
What will you look for? Which part of the vertebra is affected? Anterior superior affected, usually affected. There can be an abscess formation, and there can be osteoarthritis, and there may be extra bone formation producing sclerosis, and there may be peak-like osteophytes projecting. There may be unilateral sacroiliac arthritis. But the common diseases presenting as unilateral sacroiliac arthritis,
Ankylosing spondylitis.
that's always bilateral. Unilateral is against the ankylosing spondylitis. TB is very good. TB very common. Yes.
Reactive arthritis.
Reactive arthritis, correct. And comes brucella. That's a possibility. Brucellosis can be like unilateral or bilateral. So brucella is one possibility. Yes. So you can have these two investigations. Okay. So what are the neurological manifestations in these patients?
There can be lethargy, depression.
Meningitis or encephalitis, one rare cause of chronic meningitis. Can have abscess, especially epidural abscess. Okay, different types of abscess are seen. Other systems affected are endocarditis can be there. It's a very dangerous situation, endocarditis, yes. In clinical medicine bedside, how do you recognize myocarditis?
Tachycardia.
Extreme tachycardia means what? Tachycardia out of proportion to temperature. What's the proportion? 1:10. Okay, if that proportion is gone, you think about myocarditis. Pericarditis, how do you diagnose? A pericardial rub. Endocarditis, changing murmurs. Gastrointestinal system, what all things you get? You can get hepatosplenomegaly. Okay, hepatitis you can have. So liver function abnormalities you may get sometimes. And of course, skin manifestations. Erythema nodosum, skin abscesses you can have. Okay, skin abscess. You said the splenomegaly may be there. Tell me basically what's the function of spleen, normal human body? What are its functions? Pardon? Sequestration of microorganisms and the antigens. What else it produces? Does it have any synthetic function? Synthesizes immunoglobulin. It also synthesizes properdin. What is properdin? Properdin is used for alternate pathway. So what is tuftsin? Tuftsin is not tetrapeptide involved in the immunostimulatory effect. Yes. What is the role of spleen in relation to RBC?
Sequestration of RBCs.
Any other role?
RBC lysis hemolysis.
Other than destructive, has it got any constructive activity? In case of myelofibrosis and extramedullary hemopoiesis. So extramedullary hemopoiesis. That's very good. So it has got some functions also. So this patient is told to be having brucella. How do you treat?
With doxycycline and streptomycin. We give doxycycline
If you find that the patient is having some renal disease, do you have an option?
Rifampicin is another
Farm is
option.
an option. So, what are the side effects of streptomycin?
Ototoxicity, renal toxicity.
What are the side effects of
Attacks.
doxycycline?
Relatively well tolerated.
It is not tolerated at all. It has got a very bad gastric side effect, esophagitis. So there may be a situation where you have to change the drug. So can this disease recur? Can there be prolapses? Is it acute disease or is it a relapsing disease? Relapse occurs 50% of the cases, provided there is some adjustment the dose failure or duration of treatment is not adequate. You can have relapse of this same condition. So how do you treat a neuro case? Neurobrucellosis, how do you treat?
Ceftriaxone injection for a long duration, like 3 to 6 months. Give ceftriaxone.
IV ceftriaxone plus rifampicin plus doxycycline or minimum 3 drugs has to be given. That's a rule. Minimum of 3 months, may up to 6 months. And how to treat patients with cardiac brucellosis?
3 drug regimen: aminoglycoside, rifampicin,
Doxycycline.
tetracycline.
Okay. How long you will give?
6 months.
Minimum. So what is the mortality of these patients?
Usually response well. It's a good prognosis if treated for a longer duration.
The mortality is very high for cardiac type of brucellosis. So they respond less often. It can produce endocarditis. And the problem with endocarditis, as you know, the tissues there are not that vascular, and the antibiotic reaching that avascular areas is less. That's why ordinary case of endocarditis also treatment is always prolonged 6 weeks, because vegetations are avascular things, just like sequestrum of osteomyelitis. There are no blood vessels feeding that, so you may find it difficult to get into that area. Okay, this patient happens to be a case of Salmonella typhi positive typhoid fever. How do you treat? Needu.
Ceftriaxone 1 gram IV BD.
Okay, you have got a culture report saying that this patient is resistant to ampicillin, amoxicillin, chloramphenicol, cotrimoxazole and ceftriaxone. Multi-drug resistant.
Resistant in typhoid, ceftriaxone 2 gram can be given. Azithromycin can be given.
Azithromycin is the drug of choice for multi-drug resistant type of Salmonella typhi infection. Okay, so this particular patient, other differential diagnosis you offered was, one was tuberculosis. So how will you confirm tuberculosis in this case?
To get a demonstration of AFB.
That's right. Where do you get specimen? Lymph node may be one, so biopsy may be required. Yes. You made a bone marrow, where from you may get AFB positivity, and you may also get liver biopsy. You may get AFB positivity. You may do a CT of the circular joint. If there is abscess, you may aspirate. AFB may be demonstrated. So these are the three important differential diagnoses you think in this case possible, but there is a rare possibility of it being a retrovirus infection with tuberculosis overlapping, which may be the cause for his circular joint involvement also. So how will you confirm? How will you confirm this case of
laser test can be
A laser test can be done. So accordingly, you may be going for treatment of these patients. So articular involvement in brucellosis is said to be having very chronic process and takes a long time, and it may be disabling. It may produce abscess, it may produce osteoarthritis, it may produce secondary osteophyte formation, and it can have very bad pain in the back. On the other hand, neurological problems can have deficit or it can have high mortality. Cardiac patients, of course, mortality is very high and prolonged treatment is required.